Hello, welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist practicing here in South Florida, trained at Duke University, been here more than 22 years. I am the APD for the fellowship program, Infectious Disease Fellowship program here, and I am also a faculty for internal medicine. I chair the antibiotic stewardship for the four Broward hospitals, and I do infection control. Teaching is one of my passion, and this is something that I do. This is a focused learning session where internal medicine residents and also fellows. Today, I'm very excited because I'm excited to introduce our brand new fellow, Mahesh, and he's going to present an interesting topic, which is very important at this point of time because we are seeing a lot of these cases in US. So this session is where the fellows and residents, they research a topic and then they will showcase what they have learned. So I am so happy to introduce you, Mahesh, and the topic he's going to do is Cyclospora, and it is very important for each of you to know about it. So Mahesh, I will let you talk, and
Yeah.
excited to
Hello,
have you.
everyone. Yeah. Hello, everyone. Good morning. Hi, Dr. Gopal. My name is Dr. Mahesh, and I'm infectious disease fellow PGY4 at Broward Health North. I did my complete my internal medicine residency from Karachi, Pakistan, and I have recently joined the fellowship in infectious disease here at Broward North. And I am currently rotating with Dr. Gopal, and in a 1 month, I have learned a lot of things, and hopefully, this fellowship will be the turning point in my career. Yeah, that's that's me.
Awesome. Yeah, awesome to have you. Yeah.
Yeah. So today we will be discussing a very interesting topic, as Dr. Gopal already mentioned, that Cyclospora, considering the recent outbreak. So I will be going through the epidemiology, the pathophysiology, and the future research aspects. So let's start sharing my screen. Okay,
I can
is my
see it.
screen visible?
Yes, it's
Okay,
perfect. Yeah, okay.
okay. So we will be discussing Cyclospora infection, and this is by me, Mahesh Kumar, infectious disease fellow, PG by 4 at Broward Health North. So the Cyclospora keratinosis is the only species that can cause the human infection up to now. The infection, it's most importantly, it's involved the GI tract, both in immunocompetent and immunocompromised host. It was first discovered in 1979 in human feces. It initially called as algae, but later on in 1992 in the HIV outbreak, it is recognized as a Cyclospora keratinosis. And during the past few years, there has been several outbreaks of diarrhea associated with Cyclospora keratinosis, and its distribution is all around the world. Like it involves United States, Caribbean countries, Central and South America, Southeast Asia, in even Europe and Australia and Nepal as well. So the epidemiology, as I already mentioned, it's globally distributed found mostly in a warm climate, primarily involve the tropical and subtropical regions. Globally, average prevalence is 3.5%. The endemic countries is like Nepal, Peru, Haiti, where the infection shows the distinct seasonal peak during the rainy and summer months. And the seasonality is also observed in United States as well, which is most cases concentrating between the month of the March and the September, and it is increased in percentage around the July. Means we are in the peak season of the Cyclospora right now. The prevalent countries, like increasingly, it been recognized in the countries like Puerto Rico, Mexico, Indonesia, and Morocco. So the considering the current outbreak, it happened in May 2026. Initial case recorded in the Michigan, and later it is spread all around the US. So the source of this case appears to be related with the ingestion of widely distributed contaminated lettuce product that roots back to the Central Mexico. There's a food market, Taylor food market. From there, the lettuce spread it and then spread all around the US. Up to the July 20 to 2026, we have like more than 4,173 cases. Out of them, 308 require the hospitalization. Fortunately, we don't record any death up to now, and it is spread around the 41 states of the US. So discussing the reservoir and the transmission, the as I already mentioned, the primary reservoir is a human. Up to now, we only know the human is a primary reservoir. And the infective stage, the sporulating oocyst that I will later mention in the cycle of the parasite, that the sporulating oocysts that represent the infective stage and required to cause the disease. And the mode of transmission is mostly by the fecal-oral route. And the source is the consumption of either contaminated water or the food product like vegetables, fresh vegetables, and fruits like raspberries, lettuce, prepackaged salads that carry the mature sporulating oocysts. And it is thought that the Cyclospora is resistant or relatively insensitive to the chlorination process. So the microbiology and the pathology of this organism is the Cyclospora is obligate intracellular parasite. Cyclospora shed in stool in a non-infectious form and become infectious after a 7 to 14 days of sporulation in a warm human environmental condition. Other than this, the other trigger factor is area of active research. So up to now, we consider that the warm and environment is provide the condition for the sporulation, and it primarily involve the GI tract, mostly in the jejunum part, and leads to the jejunal inflammation characterized by increased intraepithelial lymphocytes, villus atrophy, and the crypt hyperplasia. So the life cycle of this organism, human acquire infection by the ingestion of food, water, contaminated water, or food product like vegetables or fruits in oocyst form, in sporulating oocyst. And after the ingestion, it involved the mostly the jejunal part of the intestine. In intestine, the oocyst release the sporozoites and that invade the enterocytes, and there it multiply and produce the meronte, which later turn to develop into the merozoites. And the merozoites later divide to form undergoes the sexual reproduction, form the macrogametes, the female form, and the microgametes, the male form. And both of these fuse to form the zygote and produce the new oocyst that release into the stool. And it contaminate water and require almost uh, 2 to 14 days to become mature, and then cycle is repeat. So because the cyclospora require days to week of outdoor to become infectious by the process of sporulation, as I already mentioned. So you cannot catch directly from someone who is currently having a diarrhea. So there's no person to person spread in this disease. The small intestine is show it involves the GI tract. The small intestine shows the acute and chronic inflammation, and there's a blunting of villi and hyperplasia of the crypt, and you can see the organisms in the enterocytes in the merozoites form in the apical region. Moving towards the clinical manifestations, the incubation period for this disease is around 2 to 14 days following the exposure. And there is a generally 1 days of malaise and low-grade fever, followed by the rapid onset of cramping and diarrhea. up to the seven stools per day. Most infected individual had intermittent diarrhea for 2 to 3 weeks in a waxing and waning pattern, and many complained of intense fatigue as well as anorexia and myalgia during this period. There are also few cases in which the abrupt diarrhea is containing mucus and blood, so it may present in a dysentery form as well. In special cases like HIV/AIDS patient, the symptoms may persist longer than a 12-week, and diarrhea may alternate with the constipation has also been reported. The clinical clue include a person who is like coming from the tropical areas in a summer season, and he's having an unexplained prolonged diarrheal illness. So this is the clinical clue for the Cyclospora. And the other organism that is quite similar to the Cyclospora called Cryptosporidium, which is also primarily invade the GI tract and produce these kind of symptoms in a patient with the HIV. Yes. So the diagnosis of this disease, Cyclospora, is diagnosed by stool microscopy via the detection of oocyst and parasite, and other is the stool PCR in symptomatic patients. The microscopic examination detection of the oocyst in a stool is difficult because it is shared in an intermediate way and a very small amount require multiple stool samples to be concentrated to detect the oocyst, and it's around 8 to 10 nanometer in size. And we use modified acid fast staining of the stool in which the oocyst appears pink to deep purple, and the alternative stain is for us is the saffron stain in which the oocyst appears red to orange, as you can see in this picture. So this is shows the acid fast staining in which there we can see the pinkish oocyst, and there's unstained parasites as well in the background. It is called the ghost bodies. They are also the Cyclospora. And there's another picture here for the saffron staining. You can see is that the reddish uh, orange parasite here. And the other modalities, we have the ultraviolet fluorescence microscopy. It is a more sensitive and specific method than the acid fast staining, but it requires the fluorescence microscope with a special filter. The oocyst of Cyclospora keratinaceae are autofluorescent and appears blue under the ultraviolet light, as you can see here. And the most sensitive and specific method that we are using today is the molecular testing. It is the DNA-based test that can detect the presence of Cyclospora keratinaceae in stool samples. It involves the multiplex biofire film array gastrointestinal panel that is commercially available, and it is FDA approved. The GI panel detect around 22 commonly in fact involving GI pathogens. Among the five parasite, Cyclospora keratinaceae is one of them. So the coming to the most important part, the management. As most people with the healthy immune system will recover without the treatment. If not treated, the illness may last longer from few days to month. The treatment of the cyclospora in adult consists of trimethoprim sulfamethoxyl, a double strength 160 by 80 mg tablet orally twice daily for 7 to 10 days. In patient with the sulfa allergy, we can use the nitazoxanide, that is 500 mg twice daily for 7 days, is an alternative regimen. In patient with the HIV/AIDS having a CD4 count less than 200, we require a treatment little longer. Like we can give the trimethoprim sulfamethoxyl double strength tablet twice daily for 14 days, and we also require the secondary prophylaxis with the double strength tablet about 3 times weekly to prevent the relapse. And Uh, Although the data from the small study which was conducted in Haiti in HIV patients also suggests that the ciprofloxacin might have a modest activity against the cyclospora. But in patient with the in person with immunocompetent persons, it is shown that ciprofloxacin is not so effective. In patients with the pregnancy, as we know that trimethoprim sulfamethoxyl is a category C drug, so we can use only during the pregnancy if the potential benefits justify the potential risk to the fetus. But it should be avoided near term because the potential of hyperbilirubinemia and connectors in the newborns. So, as for now, the Cyclospora is an ongoing topic of research, but there are few extraintestinal manifestations. We have a very few case reports that we observed during the Cyclospora infections. Like we have people with sometimes having extraintestinal manifestation like GBS, Guillain-Barré syndromes, and the reactive arthritis also reported. And it has also been hypothesized that it may be an environmental trigger factor for the celiac disease in patients who got the cyclospora and having a chronic diarrhea. So we have to rule out the celiac disease as well. And it may can lead to the irritable bowel like syndrome as well. And in HIV patient, it may involve the biliary tree and leads to the A calculus cholecystitis as well. Along with that, we have also seen a few case reports in which the ocular inflammation is reported, like conjunctivitis, erythritis, and episcleritis. And as these are the result of the autoimmune process through the molecular mimicry. But the research is ongoing to see either it is directly related with infection or not. So the prevention of this disease, as already mentioned, that it is transmitted by the fecal-oral route. So practice good hygiene, like wash your hands with soap and water often, using the restroom and during the food preparation. Also used to control the source in a packaging large scale packaging houses through the proper farm work hygiene and the workplace sanitation. Avoid consuming contaminated water, especially during the rainy seasons in tropical and subtropical areas. And wash all fruits and vegetables thoroughly under the running water before eating, cutting, or cooking. Scrub them firm fruits with the clean produce brush. Refrigerate them and cook food thoroughly. As there is no vaccine for cyclosporiosis and routine chemical disinfections or sanitizing method are unlikely to kill it. So area of future research is currently ongoing. There is a need of development of rapid testing kits. As the rapid testing kits are not available, so development of these diagnostic kit would improve the diagnostic yield and help to identify the source and the root of the contamination. Area also research also should focus on the cyclospora survival in the soil and water and how widespread the contamination is and what factors drive this contamination and how effectively control the parasite in the environment. And we also need the culture system to establish in vitro or animal propagation. Propagation in is the top priority because it would enable us to learn more about the drug screening, the viability, and the infectivity assays, and also it will help in the future for the vaccine development as well. So yeah, these are my references. I go through the CDC up to date, and I would like to Dr. Gopal. She shared few articles, and they are very helpful, especially the Lancet Infectious Disease 2029. So yeah,
Okay.
so this is for today. Thank you.
Okay. So that is awesome. It was an excellent presentation. You touched upon all the points thoroughly. And I love all those pictures, and it was well done, well done. Congratulations.
Thank you, Dr. Gopal.
Yeah, and so just to summarize, the pearls, I think it was all touched up in the presentation. There is the mode of transmission, the most important fecal-oral transmission, and infection control perspective, there is no person-to-person transmission, and it causes explosive diarrhea. And then we have good testing these days in the hospital. We can do the GI panel that we can do, and then we can also send the stool for AFB testing. In terms of treatment, Bactrim is the drug of choice, and unfortunately, with Bactrim allergy, we have very limited options. There has been some anecdotal reports about Cipro. The nitoxacenide is also another one. But pregnant patients, I mean, it is kind of very, very tough. I mean, so prevention would be the main focus for them. So in terms of, people love salads, but make sure they wash, and especially the raspberries, they have the crevices on the top. So no matter how good you wash it, it is difficult. So that is the highlight, when you use basil, cilantro, raspberries, lettuce, all those things, washing, that is very crucial. Of course, cooked food is always good, but people love salad. So what can I say? So that is a key feature. And I think that's all I had. So awesome.
Thank
Excellent.
you, Dr.
Thank you all for joining.